If you see a low oxygen saturation and tachycardia in a patient with no neuromuscular disease, 9 times out of 10, that is an airway clearance problem.
Hi, everyone, and welcome back to the Cripe podcast. I'm Zach Hodges. I'm a pediatric ICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin. I'm a critical care fellow at Children's National in Washington, D.C.
Alice, remind our listeners what we do here at Cripe.
Absolutely. Cripe is a collaborative educational podcast. We want to interview you and pediatric critical care educators around the world about your favorite PICU topics.
That's right. And today we're having Dr. Bill Bortcosh back on the podcast. This is part 2 of his discussion with us on neuromuscular ventilation. Dr. Bortcosh is an assistant professor of pediatrics in the Division of Pediatric Critical Care at the University of Florida. We are so glad to have him back on the podcast.
Yes, this is a fantastic conversation. He has the best clinical pearls. Let's get right to the content.
So to circle things back to our topic, neuromuscular disease, we've essentially built a case that how BiPAP is the main intervention to support these patients when they're acutely ill and developing respiratory failure. Something else that in our reading, in our script here, there are significant limitations with airway clearance. Do you mind unpacking that for us?
This is by far one of the most missed things. Like, no one taught me this in pediatric residency. I kind of had to figure it out myself. And I find that even so when I was a fellow, all these treatments were just starting to come out. The Spinraza, which is the intrathecal injections that knocks down the mRNA stuff, the Zolgensma, all of that was actively coming out. So even my attendings, I felt like didn't have a great grasp on the importance of this. But airway clearance in the neuromuscular patient is 90% of the game, 80% of the game. Like, this is so important to making sure that they don't have an event that makes everyone's day bad. So if you think about it, you're weak, right? And we do things all the time with our saliva and our snot and our lung mucus secretions, juices, whatever you want to call it, that we just don't think about. Like, I just swallowed, right? Now imagine that you are too weak to adequately swallow your saliva. It pools in the back of your mouth. And because it's a liquid, it's just going to follow the path of least resistance. So some of it will go down your food tube, and some of it will sneak down past your epiglottis, into your glottis, into your trachea, and then down into your lungs. And a little bit of spit, no big deal. But this is additive, right? If this happens day after day, week after week, and it's not being addressed, you have cumulative buildup of secretions in your lungs. They're not being cleared. Now the tubes that carry air to your lungs are plugged up with gunk, and the air can get down there. And now add a virus on top of this, right? So now you're producing secretions in your nasopharynx in the back of your mouth, and you basically increase the secretion burden by 3 times, 5 times. Even like rhinovirus can throw these kids for a loop. And it's a big deal to talk about airway clearance. And it's really important for us as not just intensivists, but all acute care doctors to just understand what it is, what's the problem, and how can I fix it?
And I can even see how all this mucus plugging would create that vicious cycle of decreasing FRC and making it very, very close, if not below closing capacity, and worsening atelectasis.
That's exactly right. So you get down there, mucus gets down there, you can't get air in, your FRC drops, you get atelectatic. All of a sudden, you're hypoventilating more, and then you have more atelectasis, and it just drops further. And these guys can just sort of like spiral out of control. So the thing is, and we'll get into the sort of nuts and bolts of what's wrong with their airway clearance and how you can fix it. But the thing is, and I said this before, and I'll say it again, and I'll say it 100 times. If you see a low oxygen saturation and tachycardia in a patient with no neuromuscular disease, 9 times out of 10, that is an airway clearance problem. They have secretions in their lungs, and you need to get rid of them. Otherwise, these guys are going to spiral. The atelectasis is just going to get worse. Their breaths are going to get smaller. The atelectasis is going to get worse, and then they're going to have an event.
Yeah.
And by event, I specifically mean a respiratory arrest or a cardiorespiratory arrest.
That's a very powerful call to action. I like the way that you categorize the different types of respiratory clearance.
Yes. So when I talk about it with my residents and fellows, basically you have 4 components of respiratory clearance. So 4 interventions that you can do for respiratory clearance, and each one of them speaks to what the problem is. So let's talk about the interventions first, and then we'll talk about the why. So the first is mobilization. So mobilization is essentially chest physiotherapy, where you're banging on the chest vest, or intermittent percussive ventilation, which is basically when you may see this at some of your institutions where they have like a mask that they put on your mouth and it like sends like vibratory like breaths into the mouth. All of those things, they all look very different and very fancy, but they're all the same thing. And in the literature, essentially are equivalent in that they basically move secretions that are stuck in the peripheral airways, like the very distal bronchioles, into more central bronchioles. So you're basically banging them up because you're intending to go in there and get them out later. So it's really important that basically everyone with neuromuscular disease, with moderate to severe neuromuscular disease, there are people with mild neuromuscular disease that may not need this as aggressively, has routine mobilization therapy. And in terms of what's better, chest PT, IPV, or chest vest, this is down at the level of expert opinion level of evidence. So when we talk about levels of evidence and how good they are, the worst of the worst is expert opinion. And then there's retrospective case control studies, there's non-blinded randomized controls, and then there's blinded randomized controls. We're talking at the level of retrospective case controls and expert opinion levels. So take what I'm about to say with a grain of salt. But essentially, compliance is better in teenagers with the chest vest, which makes sense on like the common sense level. Like, so if you're sending someone home, a chest vest is probably better if it's going to be like a tween or a teen, because they're just going to want to, as long as you can just give them a phone, they'll be fine, you know? Versus if you make someone bang on their chest, it may not happen
It's never
routinely.
gonna happen. Yeah.
And with IPV, this is very much expert opinion, is thought to be best with invasive airways, specifically endotracheal tubes and tracheostomies. And the reason is thought to be because a lot of those vibrations, if you're doing it on the mouth, can be lost to the atmosphere. So if you do them in a tube, then most of them get transmitted down and just basically shake up all the gunk better.
So your metaneb type things, be more optimistic about them if you're doing them in a tracheostomy patient versus a patient where you're just trying to.
Exactly. And you're not wrong to do two different things, especially if someone's in a pickle. So if I have my moderate to severe neuromuscular disease patient coming up with mild tachypnea, heart rate of 160, you know, say they're 8 years old or 6 years old, whatever, and a saturation 85, usually I'll start these patients on like every 2-hour respiratory treatments, including like IPV or chest PT, whatever I select. And sometimes you'll see on the x-ray that there's one lobe that's socked in. So it wouldn't be uncommon for me to say, yes, do the IPV every 2 hours, but also do chest PT localized to that like one lobe every 2 hours as well. And then I may even have the respiratory therapist and the nurse turn the patient in such a way where the side of the lung that's deflated is more vertical, more up to the air. That way air will go up to that lung and hopefully inflate it a little bit better. So there's like all these like minutiae little small decision things that can really decrease the duration of hospitalization for these patients.
Oh, definitely.
So 3 key strategies for mobilization of secretion. So you have chest PT, chest physiotherapy, vest treatments, and then IPV, which is intrapulmonary percussive ventilator for anyone who may not be aware. I know I had to look that up exactly what that meant. So we talked about mobilizing secretions. What else goes into airway clearance for these patients?
So mobilization is first, humidification is second. The thing is that when you have secretions that have been trickling down there for days, weeks, whatever, they start getting dried out, thick, nasty, especially some viruses, like say RSV is a classic example, where it basically causes the cells to fuse together and then break apart. And a lot of these secretions are filled with DNA, and DNA is a very mucousy substance. It makes everything very thick. Even if you shake up these secretions and you successfully move them to more central airways, getting them up can be difficult because they're so tenacious. So humidifying them is incredibly important. How you humidify them, that's more of a topic of institutional and personal preference. Again, we're like at very low level of evidence, like expert opinion level, because no one has really conclusively shown that one kind of humidification neb is better than another. So you essentially have lots of different options. I'm just going to list them, and then I'm going to tell you my preference. Normal saline nebs, 3% saline nebs, 7% saline nebs, N-acetylcysteine nebs, albuterol, palmazine. Those are essentially the ones that we will use. That may seem like a lot of choices and a lot of options, but firstly and foremost, I want to assure you that as long as you're doing a neb with every respiratory treatment, you can't go wrong. So when they're coming to the ICU, we're not talking about home level of treatment where they're doing it 2 or 3 times a day. Most people, in my mind, need bare minimum 4 times a day, but 95% of them, I will make sure that on their first day in the ICU, they are getting every 4-hour treatments unless they look terrible. And that's chest PT and nebs, and then cough assist, which we'll talk about in a second. And basically the pattern is, the expert opinion pattern is, expert opinion level of evidence pattern is, you start with the nebs, you moisten everything up, and then you shake it up, and then you get it out. So if we didn't have a 3% saline shortage at my institution right now, my usual preference is 3% nebs every 4 hours, chest PT or IPV every 4 hours, and then cough assist every 4 hours.
And I know sometimes hypertonic saline can be irritating to lower airways. Do you tend to pair it with albuterol or no?
I like to, but not because it works. So I've I found that 3% saline, though it gets the bad name of being irritating to the airways, very rarely, if ever, do I see a bronchospastic sort of interaction. 7% on the other hand, that will make people bronchospastic for sure. So that one I'm very careful of. One pulmonologist I learned from, no matter what, no matter whether the person had asthma or not, and this probably doesn't work. So I just do it because I like it, not because it works and I don't think it hurts. They'll start with albuterol. The idea is to open up the airways and get more stuff down there. And then they'll give the 3% saline neb, and then they'll do the chest PT, and then they'll do the cough assist. But this is not evidence proven. So like, I'm not going to jump down anyone's throat for doing anything different. As long as the patient comes in sick and gets better, doesn't really matter. But just because like the level of evidence is so low, and it really is, there's a lot of art form to how you kind of manage these patients.
Sure.
Hey, I'm Ciara Minova, a graduate student of Psychology and Neuroscience of Mental Health at King's College London, and I'm so excited to share with you my new podcast, which is called Behind the Stigma. Every other week, I will be mainly talking to the podcast clinical psychologists, clinicians, researchers, educators in the field, you name it, basically people that I find so inspiring and that will help us understand the latest research, concepts, but also complexities and controversies surrounding mental health. These are going to be some great discussions and a peek into the fascinating world of psychology, neuroscience, and psychiatry.
So we talked about mobilization, we've talked about humidification. Now let's get to the grand finale of airway clearance. Let's get expectoration.
Expectoration. So coughing. I mean, it sounds so basic, but imagine if you couldn't clear your throat, if you couldn't cough, all that stuff, you couldn't swallow, all that stuff just sits in the back of your throat and it's just dripping down there, down into your trachea all the time. And it causes problems like we discussed earlier. So when you talk about a cough, the engineers who made this were brilliant. It's important to understand the physiology of a cough. So think about how you cough. You can basically divide it into like 3 or 4 phases. First is the inspiratory phase. You take a breath in. And then there's the compressive phase where your glottis, your vocal cords are closed, but your chest is compressing against there. So you're building up a pressure gradient. And then there's the expulsatory phase, which is when your vocal cords open and basically the pressure gradient that you've created forces air and secretions out of the lungs and into the atmosphere. You know, that's why people mask during COVID, so they just don't do that as much. But, you know, basically that's the idea. So a cough assist does something very similar. You can't quite mimic the compressive phase without pushing on someone's chest and holding their vocal cords shut. But what it does essentially is it's just a very bare bones ventilator. And all it does is it gives a positive pressure and then it switches to a vacuum and gives a negative pressure. So usually the settings that I like are a positive pressure of 40 and then it rapidly switches to a negative pressure of 40. So it basically opens everything up and then sucks it all the way up. And then it basically will cause you to like bring up all those secretions. The reason I like 40 centimeters of water, and we're all so scared about barotrauma and volutrauma and all this stuff. Yes, it is 40 centimeters of water. Yes, we're taught that barotrauma occurs at plateau pressures above 30 or driving pressures above 14, whatever. But it's 40 at the level of the mouth. By the time it gets down to the chest, to the lungs, it's nowhere near 40, right? So if you're doing cough assist pressures of 20, 25, 15, you're probably not giving that person a very good cough. So if the teenager really is complaining about the 40, sometimes I'll go down to 30 or 35. If I must, I'll go down to 20 or 25. But I really want to get those secretions out because probability-wise, I am pretty darn sure that the problem is secretions. And I'm pretty sure that if I get them out, the person is going to feel better. And sometimes getting them out might not be a day. It might take 2 days, 3 days, a week. But what you should be noticing, if you're keeping up these treatments and you're being aggressive about it, every day, first off, you're going to see a lower heart rate. You're going to see a higher oxygen saturation. Their wicker breathing, which was subtle, is going to be better. And furthermore, my favorite physical exam sign with these guys to test for secretions, which I think has an incredibly high sensitivity for feeling for secretions in any intubated neuromuscular patient, is tactile fremitus. So oftentimes I don't even bother with auscultation because it's just going to sound like a roncorous mess. But I will just put my hand on their chest, so. And if I feel rattling, to me, that's going to be secretions. Like we're taught in med school that tactile fremitus is very specific for pneumonia, and that is true, but not very sensitive for it. But tactile fremitus is incredibly sensitive for secretions. And the nice thing about it is that after you do a bunch of these treatments, you're going to feel that tactile firmness reduce or go away altogether, such that you know that your treatment's doing better, along with those sort of vital sign patterns that we just discussed.
I hadn't operationalized that maneuver as tactile firmness, but I can tell you that that's what our respiratory therapists do right before they ask you to schedule the respiratory treatments.
Of course, they just put their hand on the chest.
Yeah.
So respiratory therapy, just like medicine, we overcomplicate it. It's not, in essence, it's not that hard. And there's a lot of minutia you need to know, but once you truly understand it, it comes down to just a few simple things. And in this case, neuromuscular patients, they don't take big breaths and they have a lot of secretions, and you need to give them big breaths and you need to get those secretions out. That's essentially the problem here.
Yeah. So we've talked about mobilization, humidification, and expectoration. One thing I didn't hear you mention was scheduling some glycopyrrolate. What do you do if someone suggests trying to dry them out?
It's such a double-edged sword, right? I wouldn't be upset about it, but everyone is so unique. So the problem is because these guys are weak, yes, glycopyrrolate or scopolamine patch can dry out these secretions and maybe reduce the frequency, but theoretically it can also thicken them up. So if you have really thick, tenacious secretions and then you make them more thick and tenacious, one fear that I have is that you would have a big ball of secretions that you can't get out and without a bronch. And I really don't like to intubate these patients. The reason being is because they're so weak, and when you sedate someone or even have to paralyze them, inflicting neuromuscular weakness like a critical illness myopathy becomes so much more common. The rates of tracheostomy in patients with neuromuscular disease who were previously intubated is way higher than in the population. So for that reason, I personally prefer not to. If you want to reduce secretion burden in this patient population, I think the better avenue long-term is to consider either Botox injections, or better yet, to avoid the repeated OR visits with anesthesia, to consider salivary gland ties if repeated admissions are becoming a really common problem. And that's often involves looping in your ear, nose, throat team to help you guys. And very rarely will they do this kind of procedures inpatient, but getting them kind of connected can be really helpful in the outpatient term and preventing readmissions.
Sure. Yeah, very helpful. So kind of thinking about the take-home points that I'm going to bring from our conversation is our patients with neuromuscular disease, they have a lower FRC, and that predisposes them to atelectasis. They also have the tendency towards these inefficient, paradoxical chest wall movements that really makes their ventilation ineffective. And they have disrupted order of breathing, so whether it's obstructive or these pseudocentral events, kind of all on top of these impaired airway clearance. Thinking back to our case, I know it's difficult to be prescriptive, but say you had that 6-year-old with a neuromuscular disease, say it's SMA, they're coming in, they're in distress, their mental status is sharp, so you're not worried about them needing a breathing tube. How would you start off their prescription for their BiPAP? Would this be like a PEEP of 5 and a delta of 10? Where would you start?
This is a good question. And usually in someone who has atelectasis, you would say, I need a high PEEP. So our pulmonology team, when we started getting these patients too, was very interesting because they were terrified of high PEEPs in these patients. And the reason being is that in a lot of the longitudinal literature, it showed that patients with neuromuscular disease and high PEEPs had higher mortality rates, which was fascinating. But what I told the pulmonologist then, and I'll say it now again, is that you're in an ICU. I'm not going to let you die unless I have no choice. And a pneumothorax just isn't going to do that. So I'm sure that they did have worse complications in the outpatient setting. But so that being said, I do tend to avoid high PEEPs in this patient population. So you can use it, but the reason I tend to avoid it is because when you use a high PEEP, you can load the diaphragm, and making the diaphragm contract under a lot of pressure can actually increase the amount of energy required for the diaphragm to contract. And already these guys are very weak. So I will often use a PEEP in the 5 to 7 range. Short term, if they're really bad, I may use a PEEP of 10, even 12, but I really try to stick in the 5 to 7 range. And I get my tidal volumes in that really sweet spot in that 10 to 12 per kilo tidal volume range, oftentimes 12 per kilo. And I start airway clearance right away. This can be really difficult for emergency medicine providers to do because they often don't have all the equipment there. But what I would encourage folk, if they were just kind of receiving them in the EMS setting or the emergency medicine setting, would be to just do your best to manage their secretions. Don't stress about it if you don't have a cough cyst or whatever. If you want to just suction their mouth, you have some chest PT, great. But otherwise, just put them on BiPAP, kind of get them settled, get their vital signs appropriate, try to get their tidal volumes, even on BiPAP. I know that's not as accurate, but like in that 10 to 12 per kilo tidal volume range. And then we'll get them up to us where we have all the cough assist, all the nebs, the frequent respiratory therapy. And again, on the BiPAP, aim for that 10 to 12 per kilo. Do a 5, tops like 7, 8, if you must, PEEP. But remember, like the oxygenation issue with PEEP, if you're trying to oxygenate with PEEP, it's just a physiologic trick. It's not solving the problem. The reason PEEP works from an oxygenation standpoint is because it increases the total amount of pressure. So 21% of a pressure of 3,000 is going to be more partial pressure of oxygen than 21% of a sea level pressure of 760. It's just a trick. All you want to do when you're thinking about how do I care for this patient is I want to get the secretions out and I want to unatelecticize. I want to recruit all that lung that was collapsed. And if you do that, they're going to get better, right? It's okay that their SAT's 80, 85, 90. As you re-recruit that lung, it will come up. People can live at a lower SAT for a very long time, but addressing the issue promptly, you'll see better SATs. You'll be able to oxygenate better. And I would also encourage people, if you can, to try to avoid FiO2. And the reason for that is not because I think the FiO2 is going to hurt them or anything like that. It's that if I see a low oxygen saturation on a patient with neuromuscular disease, that tells me that my work here is not done yet. Again, their SAT should live in that 96 to 100% place. And if it's a really like older patient, they'll tell you, oh yeah, my SATs are 94 to 96 usually, or their family will tell you that. But if they're sitting at 92, 93, but they otherwise look well, that would not be a discharge home for me. That's like, no, we're gonna keep up with our airway clearance. We're gonna get you perfect before we send you home, because otherwise you're just bouncing back. So my delta is often whatever I need to get that 10 to 12 per kilo tidal volume. My PEEP is usually 5 or 7, and then I usually have a backup rate of 5 or 10.
So the high PEEP is a physiologic trick to oxygenate someone if their lungs cannot oxygenate adequately.
Correct.
In patients with neuromuscular disease, hopefully it's not too much of primary lung pathology, and so you should be able to just give them the tidal volume they need, give them the pulmonary expansion they need, and send them on their way.
Exactly. Like you can get a really good mean airway pressure with just a high tidal volume and a low to moderate PEEP. And I should say that PEEP is helpful for preventing atelectasis in patients with restrictive lung disease. So secretions are a type of obstructive lung disease. It's just stuff is in the way. But in restrictive lung disease like ARDS, where the lungs just want to slap shut, PEEP is a useful tool to like help just kind of keep everything popped open. But if you're using PEEP in like your bronchiolytic or stuff, it doesn't address the underlying problem, which is that there's secretions in the way, and it's just kind of like shoving the secretions at the side of the airway to get air in there and a higher pressure in there. So really like addressing the core cause, the common cause is getting the mucus out.
Gotcha.
And tell me this, would it be fair to say that a patient with neuromuscular disease, you might be willing to offer them a longer trial of non-invasive on higher pressures and higher FiO2s as compared to a patient with developing ARDS? So that'd be fair to say or no?
In my mind, anyone with moderate to severe neuromuscular disease probably needs at least nighttime BiPAP. And unfortunately, like these cures, these treatments, Zolgensma, Spinraza, there's another genetic one that's came out or is coming out that I forgot the name of that's very similar to Zolgensma. They are treatments, but not cures. So oftentimes, like these patients will still have some neuromuscular disability. It just wouldn't be to the degree which would have been predicted 20 years ago, which is fantastic. Like they have wonderful outcomes. They can live more wholesome lives, but oftentimes these guys will hypoventilate at night. They'll have some pseudocentral apneas. They'll have obstructive sleep apneas, and nighttime is going to be their most vulnerable time. So maintaining airway clearance and keeping BiPAP on, usually at least at nighttime, is kind of like the bare minimum I would say for like a well neuromuscular patient. And I would try to avoid intubating them just because of that risk of tracheostomy, and the more machinery dependence they have is just like a big quality of life problem for these guys. A person with ARDS, true ARDS, I think I could count the number of people I was able to get by on BiPAP on one hand. Like they crump so fast. It's just very challenging. But if you are able to get by with BiPAP, you could argue both ways. Like some people will say that BiPAP will prolong the hospitalization and prevent appropriate airway clearance and lung inflation in patients with ARDS. Other people will say that you're minimizing opioid and sedation exposure and you're thus decreasing their hospitalization. I mean, this is such, again, like it's a very difficult argument to make because because it's hard to standardize these patient populations and compare them to each other. So that kind of ambiguity, it makes our job as intensivists very valuable. It makes your role very valuable. It makes you indispensable. So, robots or other folk just aren't going to be able to do that. So you're going to have to like learn this art form, learn your preferences, figure out what works for you, what doesn't work, figure out the pros and cons of each. And some of those pros and cons are like very minutial, and you just get to know them the more you do this kind of thing, And the reason I know, for me personally, that I like to ventilate them at 12 per kilo, that I like to use lower PEEPs, that I like to do Q4 clearance, is because for me, when I didn't do those things or I did less, they had more atelectasis and they had more events, and like they would stay in the hospital forever. And then I developed a pattern where I feel like they're in the hospital a lot less than they were when I was a junior attending or a fellow. And I just think it works better.
Oh, yeah, absolutely. It's also, as a fellow, I found this to be a great teaching point for residents that just roll on service is if you're telling me the BiPAP settings are 16/8, 50%, 60%, you're telling me probably that we need to think about intubation very seriously. And so if I hear those settings and my immediate teaching point is let's discuss the indications for intubation just based on those settings in isolation, and then you maybe tell them to be for a teenager who's a neuromuscular patient who doesn't have pneumonia, who doesn't have a big effusion, anything like that, then I'm going to think about it differently. Is that sort of what you were thinking?
Exactly. I would totally agree. So if I heard that in a neuromuscular patient, my gut instinct would be, I do not want to intubate this patient, but I'm worried that we're going to have to if we don't do something right away. And so where I would probably go in the room and I'd tell them, I'd put my hand on the chest. I'd probably feel those secretions rattling around everywhere. I'd have my RTs and my nurse be like, look, we have to do at the very least Q2 hours of airway clearance, like NEBS, chest PT, cough assist. And even for the next 3 hours, if you guys could do every 1 hour, these rounds, and just get this stuff out of there. Like I will stay at bedside with you and do this. And then what you're going to see as you get all these secretions out is that your compliance is going to rapidly improve. Your saturations are going to rapidly improve. Your tactile fremitus on palpation is going to rapidly improve. And you're going to see with every glob of mucus that comes out of their mouth. And in a way, it's like very satisfying because you get immediate feedback. And I think that's why a lot of us are attracted to acute care, because you see a problem, you understand a problem, you fix the problem, you have immediate feedback, and it's just awesome, But yeah, I would try to avoid, unless they were crumping. The last patient I had to intubate with neuromuscular disease, he had very rare disease. He came in breathing like deep retractions, which you very rarely see, kind of obtunded, satting 70. The mom's like, he just does this. He's just anxious. I'm like, oh, I'm pretty sure he's not anxious. But, and she's not, difficult's the wrong word. She's strong-willed and wants it her way. And I'm like, all right, well, look, we'll sit at bedside together and I will give him a little bit of Prestex and we'll watch and we'll do some airway clearance. And so we just sat and watched him together, watched him get progressively blue, sit in the 70s. After like about 30 minutes, I'm like, look, this isn't working. And she's like, I agree, it's not working. Mm-hmm. And so we intubated him. And sure enough, we couldn't extubate him and he needed a tracheostomy. So it's hard. And these guys, they live in the country, right? Like this is a hard ask for them. They're on Medicaid. Like they it's hard for them to find nursing. They're good people. They have other kids, like, and stuff, like it's hard. Like life is hard. So like putting this machinery on them is like such a big ask.
Oh, definitely.
For sure. I've really enjoyed our conversation. I think it highlights the core content and knowledge that we need to know as fellows, but also it was very practical. And I really appreciate your perspective and some of the things where maybe the science isn't so worked out, but we still have patients in front of us we need to manage. Anything else that you wanted to mention before we wrap things up?
The only thing I'd add with these guys is that we kind of didn't talk about it, but it comes into like the long-term care of them too, is that while they can't manage secretions that well, they also, a lot of them can't manage food that well. Mm-hmm. Keep in mind that aspirations can happen a lot with these guys, and it's pretty common that many of them will require a G-tube at some point, and oftentimes with the Nissen fundoplication is currently, again, at expert opinion level or like case control level evidence recommended to sort of prevent aspirations, but that's what a lot of our patients end up with in the long term. Not right away, but you can kind of see how things shake out after trying the Spinraza and Zolgens, but just something to keep in mind if you're seeing a lot of admissions, because you guys as intensivists are going to get to know these patients very, 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 very well and their families very well. You're going to figure out like, this is our 5th aspiration in like 3 months. Like, let's talk,
Yeah. And your role of sort of stepping up that level of mechanical, devices that can really help keep them at home.
Right. And advocating for the family, like understanding their interests and helping them articulate them and helping guide them down the path that makes the most sense for them. I've had families who they still see quality of life with machinery and they want it all. And I've had some families who they would rather that their children live a shorter life without machinery because they think that they're happy that way. And then being mentally, morally, and emotionally flexible, it's such a hard ask on us because it can be very spiritually draining because a lot of us come in with these beliefs. But this is an extremely challenging population, not just from a medical standpoint, but from like an ethical and a long-term medical care standpoint, where what is right and what is wrong becomes very gray, and it can be extremely challenging. And I know that's a little bit heavier than more like the lighter physiology stuff that we talk about, but for me, it's a reality with this patient population.
Sure, it's very important, and it's something that we need to lean into and walk through these steps with our patients and their families, because I just can't imagine what it's like for them.
Yeah, it can be so wearing on them, and like the strength I see in these families, is incredible.
Can I end this podcast with a fun fact that I think is a little bit of a lighter note?
Yeah, go for it.
Okay. Thank you again for coming. Thank you for listening. If you want to listen to a podcast by someone with SMA who, as a grown woman, has 24-hour nasal BiPAP that you can hear on the podcast, her name is Alice Wong. She is incredible. Her podcast is titled Disability Visibility, and she also compiled and edited a book of short stories of individuals with disability who write about their experience, and the cover is awesome. So, to hear from a first person about SMA and about experience with disability, you should check out Alice Wong.
Nice. I like that. I'll probably check that out too.
Well, sounds great. How about we leave a link for that podcast in our show notes, and also a list of our references and everything else that Bill provided for us in our handout. And again, Bill, thank you so much.
Seriously, thank you.
Oh, thank you guys for having me. It's a pleasure as always.
And thank you for listening to this episode of Pete's Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Pete's Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Pete's Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.